So just to step back to the sort of overview, the definition of acute chest syndrome is really quite important. It's essentially any new chest X-ray changes in a child or person with sickle cell associated with onset of respiratory symptoms, and that can be anything. It can be cough, fever, pain, hypoxia, or wheeze, and it covers the whole spectrum. So you could have a little 2-year-old with a lobar pneumonia who actually looks quite well, through to somebody like the patient you've just presented. So it's important to give it its name. I think when children get labelled as chest infection or lobar pneumonia, and it needs to be called chest syndrome in order to highlight the risks of the risk of deterioration and the need to escalate treatment appropriately. We know the etiology is quite complex. It's often infective. We don't always identify an organism. There's a crossover with asthma. Children who have asthma as well have both their conditions are worse. They tend to have more episodes of chest syndrome, but equally their asthma can be harder to control. And then if in a number of cases it develops on the back of a painful episode, and it's thought that particularly with lower limb pain, you can get marrow infarction, and then microparticles can travel up to the pulmonary vasculature where you get inflammatory changes, and it can kind of trigger acute chest syndrome. There's a much more severe problem, which I've named the fat embolism, which I'll cover a bit later, which is a bit more dramatic. But also there's thromboembolic problems, and overall there's endothelial dysregulation, which is part of the whole picture. And as I said, in 50% of cases of acute chest syndrome, they develop on the back of an admission for another reason, typically painful episodes. So this is why it's so important to keep revisiting patients and assessing, because they will come in with a clear chest, no signs whatsoever, and then 24 hours later you're looking at someone who's developed an oxygen requirement. So it's really important that you've got early recognition and intervention. Any person under the age of 20 who has an episode of acute chest syndrome has an association with risk of increased mortality. And anyone who's had an episode of acute chest syndrome in the previous 2 weeks is at higher risk of having an acute stroke, and it's thought to be related to the inflammatory changes that it sets off. And those who are unlucky to get recurrent episodes, some of them do go on to get restrictive lung problems, which are lifelong, and there's also an association with pulmonary hypertension, which can be a problem in adults in particular. So I'm just talking generally about the overall supportive management. Going to talk about pain. Obviously, we have sort of protocols for this, including starting with paracetamol and non-steroidals and escalating to opioids fairly rapidly. I'm going to talk a bit about fluids and the need for physio and the management of the oxygen levels, and then the modifiable factors such as specific infections, transfusion and bronchodilators. So starting with pain, this is almost always present, although young children may not have pain. They may just have a cough and a fever, but it can be pleuritic pain, it can be only pain from rib infarction, but almost always associated with the splinting of the diaphragm, where they can't take deep breaths because of the pain involved, and that then leads to atelectasis, particularly in lung bases, and failure to ventilate the lungs, which leads to more hypoxia and deteriorating picture. So, as I'm sure you're familiar, there's ways to assess pain in children, which can be related to their age, and the use of charts to try and score it, so that it needs to be assessed pretty quickly, and effective analgesia given within 30 minutes, as with any painful episode, and then give treatment, but then you need to reassess again within the hour to see how they're doing, and again escalate if needed. So for mild to moderate pain, the standard treatment would be for paracetamol and initially ibuprofen, but we do use diclofenac if needed, and some patients do get ketorolac, but we'd be a bit worried about using that for more than sort of 48 hours continuously because of the risk of renal problems and also the gastric irritation, but they can be effective in older patients. For more severe pain, we'd be using opioids. We'd start with Oromorph, but if that's not effective, rapidly move to PCA or NCA, and usually we'd start with a bolus set up with a lockout period, which can be used, but then you can go to a background as well, which will give a very small dose to help give background analgesia. We do find patients who don't tolerate morphine well. Some of them need to go onto fentanyl. And for those who really reach the ceiling of what can be achieved with the opioids, they have the addition of ketamine as an opioid sparing agent and some various permutations. And again, I'm not sure what's possible here, but we'd certainly look to achieve adequate analgesia. It's almost impossible to achieve complete pain relief without sedating someone very significantly, which in this setting in particular is high risk. And you always have to have the reversal agents prescribed. The naloxone needs to be available and prescribed just in case they do run into problems with respiratory depression. Quite a few people feel sick with the opioids and they need ondansetron PRN, and laxatives need to be started at the beginning because almost everyone will get constipated. You then get abdominal pain, doesn't help with ventilation, and it can, just to keep on top of that, itching can be another problem. They may need antihistamine. In terms of fluids, historically there used to be a wish to use so-called hyperhydration for sickle episodes, but I think we really don't use those now. There may be exceptions where someone is known to be dehydrated, and if so, you would only use hyperhydration for the first few hours, but I really would not encourage that as a standard approach. You would try to use oral fluids, but for some of the children, particularly those getting into difficulties, you have to move to IV fluids, and you'd want maintenance fluids really, and modified for losses and fever. And the key to this is accurate fluid balance on the ward, and it's amazing how difficult that can be sometimes, but there is a significant risk of fluid overload which will worsen any anemia. They'll get dilutional anemia and also worsening of their acute chest syndrome. We know now intensive spirometry is extremely good at preventing the development of acute chest syndrome in post-op patients or anyone who's lying in bed immobile on opioids or with abdominal pain, for instance. And there's been randomized control studies. Unfortunately, most of what we're going to talk about there aren't evidence-based studies because no one's really done those. It's just how practice has evolved. So, but there is evidence for this one. And obviously in little children, they can't use these. They need to be blowing bubbles if they can. But if they do run into problems with acute chest syndrome, this becomes increasingly difficult. And if they're on Optiflow and needing more oxygen support, it's impossible to do this. But it's very good practice for anyone being prescribed any opioid in hospital if they've got sickle cell disease. So in terms of oxygen saturation, I'm just going to talk a little bit about the sort of physiology of this, because it does differ slightly in sickle cell anemia. As I'm sure you all remember very well, the oxygen dissociation curve. In people with HBS, they have a slightly different oxygen affinity. So the idea is it gives up its oxygen more readily to the tissues. But the problem is you have then an effect where for a given oxygen tension, environmental oxygen tension, you tend to have a lower percentage saturation, which means that the curve becomes steeper sooner for these patients, if it's sort of making sense. So they sort of desaturate more quickly, and it's the desaturation that causes the HBS to polymerize. So red cells made by patients with sickle cell will be made in the normal biconcave shape. They'll come out of the bone marrow in that form, and it's only later that they sickle. So anything that will promote sickling will cause that to happen more. And it's once they've sickled, that's irreversible. They hemolyze, but also cause occlusion in the small vessels. So maintaining oxygen saturations is really key. So as I've just said, it's the polymerization of the hemoglobin S molecules. They go into kind of rigid Christmas tree shapes, which distort the red blood cells, and they just get destroyed and broken down. Also, you get release of free hemoglobin into the circulation, which scavenges nitric oxide, and that is, you need nitric oxide for vascular tone maintenance and also sort of regulation of endothelial molecules. There's this thing called VCAM1, vascular adhesion molecule 1, which it's thought to be quite involved in a lot of inflammatory processes, but it certainly makes sickling worse. And if you get upregulation of that in acute chest syndrome, in the absence of nitric oxide, it probably is part of what's going on in the lung vascular bed. this diagram sort of illustrates a little bit about how infarction in the long bones, particularly in the lower limbs, can lead to these microparticles which travel to the venous circulation and then go into the pulmonary capillaries and can cause further inflammation and occlusion, and you get this downward spiral. So just to talk about pulse oximetry, I'm sure you're all aware there's been quite a bit of controversy about this recently, and it's really on the back of what happened during COVID, where there were significantly worse outcomes. This is not patients with sickle, this is any patients from different ethnic groups who had worse outcomes, and it seemed to be people particularly with darker skin. And it was recognised, and it has been known for decades actually, that pulse oximeters are not particularly accurate in people with darker skin tone, and it's not a direct correlation, so you can't sort of look at a graph and read off a reading that you would adjust for, because it varies with individuals. However, people with darker skin tones are most affected, and it means true hypoxia can be missed. And for instance, in this study of adult patients, again, not sickle cell specific, but if the oxygen saturation was reading between 92 and 96%, patients who are black were 3 times more likely to have a saturation of less than 88% if you did arterial gases. And this was obviously during COVID, they were doing a lot of arterial gases, and I think it really highlighted the problem. And it also showed that if your SATs aren't accurate, you're less likely to be given oxygen, and it did lead to worse outcomes in those patient groups. There's probably other factors as well, but this was certainly one of them. So that's one thing to be aware of. The saturations are not the whole picture, and you've always got to keep a slightly open mind about them, because they could be worse than they appear to be. The other situation is when there's severe anemia, they become less precise, and in fact they can underestimate the oxygen saturation, which is not so much of a problem, but just to be aware, they're not perfect. We've got oh yes, sorry, this is this thing that's been produced and updated. There is a kind of initiative nationally to try and address the effect of racial bias and pulse oximetry, and it does involve looking at all oximeters, assessing them, looking at introducing new technology and researching this. So although I don't think anyone can sort of stop using their current oximeters, there's a plan to try and get rid of this inequality that arises from this. But in the meantime, because it's clearly not happened yet, vigilance, and you've just got to carefully assess the patients and always consider that the saturations may not be as accurate as they appear, and they may be underestimating the true picture, especially if the patient's deteriorating. So in terms of oxygen support, we would say aim for near 100% oxygen saturations in acute chest syndrome, and if the saturations are less than 95% or more than 3% below steady state, some patients do have a low steady state, then you definitely got to get the oxygen on and improve those saturations. And initially it's reasonable to use mask or nasal cannulae, but the thing to do to kind of get a feel for how this is going is work out how much oxygen they need to say. If they're 92%, get them up to over 98%. How much oxygen are you needing? And then you revisit that, do that again in an hour, turn off the oxygen briefly and see if they were 92% an hour ago, do they now desaturate down into the 80s? And you can kind of begin to get a sense of what the trajectory is, and that can be a clue to someone who's on the verge of deteriorating, that their desaturations are going lower, even though you're managing to keep them in the right zone. And obviously with time, that oxygen requirement is likely to go up. So for the patients where you're not managing to maintain their oxygen saturations with just simple mask or nasal cannula, you need to move quickly to continuous non-invasive ventilation. And you would identify these patients. It's things like worsening increased work of breathing, increasing oxygen requirement, and particularly if they're developing drowsiness or just not tiring badly, those would be worrying signs. And definitely need to involve HDU and PICU if you think that's the way things are going. we've just been talking about the use of oxygen for so-called comfort, which again, not in this setting, but in patients with, say, painful episodes. And there's been some evidence that actually just giving oxygen to someone who's got normal saturations and a clear chest may actually be harmful. You can actually switch off their EPO drive if it goes on for several days, because they will stop making red cells if they get the signal they don't need to, because they've got very high oxygen saturations. But there's also potential for oxidative damage with high flow, high oxygen, inspired oxygen. I mean, I think it's difficult because if people ask for it, but you can use fans for that sort of sense of something flowing. But I think to just stick an oxygen mask on someone who doesn't actually need it physiologically, it's possibly not ideal. So the thing I think we all value enormously now we've got it is Optiflow, because it seems to be very well tolerated. Again, we've got no randomized controlled trials comparing this versus face mask or versus CPAP, but it's accessible and it's safe, and you can get it started on the ward or in ED, and it's thought to be helpful with secretions, which can be a problem. It also deals with the peak inspiratory flow demands and slightly reduces the muscular work needed, and it provides some end expiratory pressure, which helps with the atelectasis and slightly increasing the functional residual capacity. So they're all marginal benefits, but they definitely seem to help, and they also wash out some end tidal CO2. So definitely start if you think the ASATs are dropping into the 80s and they're not maintained on face mask oxygen. If you've got someone where they've got multilobar involvement on the chest X-ray, or it's progressed, like the one patient we've been discussing, and mild to moderate work of breathing, there's lack of evidence again in a formal setting, but I think that would be a worrying sign that they're not managing and they need more support. So even if they stabilize with the Optiflow, it's always good practice to discuss them if you haven't done so already, just to kind of get a plan for what's happening next if they don't maintain stable and they deteriorate further. So obviously the next stage would be CPAP or BiPAP, but this is patients find this really unpleasant and struggle with it. They obviously have got a mask clamped on, they can't eat or drink, they find it very oppressive, they can't sleep. But we do use it in HDU setting for some patients, as this patient did need when they were extubated for a while. But the risk with it is that if they're at all sedated, they might have needed sedation to get lines in, for instance, for an exchange. There's a risk of aspiration. So you really do need it used in a safe setting. The next step would be invasive ventilation, and approximately 10% of cases of severe chest syndrome do progress to need this, and this clearly has to be done in ITU. But the initial intubation, absolutely, it can be what's required to stabilise them prior to transfer, and it's far better that's done in their hospital of origin rather than running into problems in an ambulance. And then ECMO can be used in the most severe refractory cases. It's obviously complex, but they can get through this. They need red cell exchange, because clearly using the ECMO circuit will lead to sickling of everything they've got, which would be disastrous. So you need to do an exchange before you can institute that, but it has been used for sickle patients. So coming on to infection now, we know that acute chest syndrome is probably about 3 times more common in the winter in children, and that's likely to be infective in origin. As we know, children with sickle have a hyposplenic state from a very young age. They're particularly at risk of strep pneumonia, invasive species particularly. So they're all should be on penicillin prophylaxis from a young age, and now they all get Prevnar, and we've now got the new Prevnar 20 vaccine, which is replacing the Pneumovax, which is the old unconjugated vaccine. So that should be coming along for everyone soon. In fact, strep is probably only isolated in about 4% of cases, and it's certainly in France they demonstrated that since the introduction of Prevnar there was a very significant reduction in invasive pneumococcal infection. So we would certainly strongly encourage the vaccines for everybody, and the addition of the Prevnar 20 at the age of 2 and then 5 yearly. In the States, they found that mycoplasma and chlamydia were responsible in older children in about 30% of cases, and this is largely what's behind the use of atypical cover in chest syndrome, just in case those things are there. But I think we sometimes get mycoplasma, but I don't think we very often come across chlamydia, but we still cover for those things. And then obviously the use of viral swabs has been hugely informative in terms of identifying all the various viruses that could be implicated. We know RSV can cause bad acute chest, certainly flu can, and they're all advised to get the flu vaccine annually, and COVID-19 definitely also associated with acute chest syndrome. So that's an ongoing issue. We sometimes send pneumococcal antigen in the patients who end up in HDU and ITU. Often it is positive if they have an invasive pneumococcus, but I'm not sure it's particularly helpful first-line test. So in terms of the antibiotics, so obviously these have to start empirically, and the first-line standard would be cefuroxime and clarithromycin. For those who have got severe penicillin allergy or anaphylaxis, if they're not severe, as in they're fairly stable, just getting started, you can just use IV erythromycin as a single agent or oral clarithromycin if they can take it. But we usually move fairly rapidly to second line for those patients who are deteriorating. We don't necessarily have to have cultures or anything for this, we would just move onto it. So for those without penicillin allergy, we would use tazocin and gent, and then giving a single dose if they appear to be running into problems with septic shock is reasonable, and you can always assess whether you need to continue it or just give the one dose, but also the atypical cover. For those with non-severe penicillin allergy, that would be, we can use meropenem and gent and then the clarithromycin. But for those with documented severe penicillin allergy or anaphylaxis, it would be vancomycin, a shot of gent and clarithromycin. A recurring discussion is the use of ceftriaxone, which I know is used in many hospitals as an empirical first-line antibiotic. I think that we have a difficulty with it because there are publications where it cites it as being associated with increased mortality due to hemolysis in children with sickle cell anemia, and that's our anxiety about it. The using it empirically when there are alternatives is not ideal. We have had children who are transferred to us for ITU or HDU support who've come with very severe hemolysis on top of their acute chest syndrome. We don't identify any antibodies, but they have had ceftriaxone, and we just worry that that has probably not been a helpful thing. So we would always advise not to use ceftriaxone based on the published evidence and also our experience. There is a place for it, but we would suggest it's reserved where if you've got positive cultures, for instance, Salmonella osteomyelitis, where you've got to give 6 weeks of treatment and it's sensitive, then it is reasonable to use it as a targeted antibiotic with monitoring. But I think to just give it empirically, it does carry a risk. We would suggest using antibiotics for 7 to 10 days as guided by cultures, but children can be switched to orals if they're clinically improving and fevers are settling. Always consider the antiviral agents if you do detect flu, for instance, or COVID-19. And I think we do know that in children who get invasive, who have severe viral infections, probably it's the inflammation in the respiratory tract which sets them up for invasive bacterial infection. And certainly some of the most severe children we've seen with sepsis have had a detectable respiratory virus with a few mild symptoms, and then they come in with septicemia with their overwhelming pneumococcus, which has probably gained access via the respiratory tract. So I think you do need the antibacterial cover as well. So in terms of blood transfusion, this is really a cornerstone of treating acute chest syndrome. Almost all the children are anemic, not all of them are. Children with SC often have high hemoglobins, but some are significantly anemic. And what you want to do is increase the hemoglobin and the oxygen carrying capacity, but also reduce the percentage of sickle hemoglobin in the blood to try and arrest that downward spiral of ongoing sickling. So you would always aim for a simple top-up transfusion in the first instance if you can. that is if there's space to give it. So I'll come to that in a second. And the blood you request has got to be sickle negative, and it needs to be matched for their ABO blood group and their RH blood groups. That's the big C, little c, big D, little d, big E, little e, and KEL. And all patients should have had this done routinely in the clinic. So the blood transfusion lab know, and also an antibody screen. So if there's any history of any red cell alloantibodies, you also get antigen negative blood for them. And the transfusion service is usually very good at providing this quickly. There are some patients where this can add delay if they've got complicated alloantibodies. So it's really important when they're admitted to get that group and screen off rapidly, just in case in a few hours' time you're going to need to start getting blood for them, and the lab can be alerted to that. The the NHSBT, the transfusion service, is now introducing genotyping for blood groups for all patients with blood disorders like thalassemia and sickle, with the aim of getting a really clear full genotype for them, which will then obviously be their lifelong genotype and can in future aid matching blood in patients where it's getting difficult because of antibodies, and reduce the risk of further antibody formation. So you're going to think about transfusion where there's hypoxia, oxygen requirement, falling hemoglobin, increased work of breathing. And what you have to always bear in mind is that you can't give transfusion over a hemoglobin of 100 in a previously untransfused patient, because sickle blood is very viscous, and the rheology is such that once the hemoglobin goes above 100, the viscosity goes up in a non-linear way, and you are more likely to get sickle complications such as stroke, worsening sickling in the chest, and any other organ involvement. So you can only top them up to 100 at the first attempt. So in someone with a hemoglobin of 70 to 80, that's okay, you can just top them up. But if their hemoglobin's over 90, you can't really give a useful transfusion. They just can't get enough volume in. And these are the patients where if they're deteriorating, they are almost certainly going to need, if anything, they're going to need red cell exchange just to create space to give them a bigger volume of HbA blood to stop the sickling and get the hemoglobin up. The decision about whether they have a manual or automated exchange is very much to do with what's available where they're going. But what you're trying to do there is to get the sickle percentage down to less than 30%, so that 70% of their blood will be hemoglobin A, and that usually helps to turn the situation around. But the simple top up also works well, provided you've got space to do it. It's probably not necessary to send a sickle percentage before starting the transfusion, but it is useful to send one afterwards so you know what you've achieved, and then it might guide the need for further top-up transfusions. So in red cell exchange, this would be really for the severe acute chest syndrome or deteriorating patient, or those where you can't get any blood in because they've got a hemoglobin above 90, or someone who's already had some blood and they're still getting worse. And this is done in an HDU or PICU setting. You need an in and an out line, and this can be done with 2 venous lines in older children, but usually in a smaller child you need an arterial line. And this would involve some sort of sedation to get the line in, and clearly that's got to be done safely due to the risk of sedation. Some places have got apheresis machines. I think the Evelina have got a very good setup where they can do this. At King's, we tend to rely on manual exchanges out of hours, but with a bit of organisation, they can have automated exchanges using an apheresis machine, and it's usually very well tolerated. And what you're doing is you're removing whole blood through the venous outline, and you're replacing packed cells and saline in a calculated, there's a formula to calculate the volume of each to replace accurately. In the person who comes over with, say, a hemoglobin of 90, you do a venous section first to remove blood before you then start the exchange, because the hematocrit of packed red cells is quite high. It's 60 to 70, so you can't just give it as it is. You have to give saline with it, but also create space beforehand. So bronchodilators are recommended certainly a patient who's got wheeze, a patient who's known to have asthma, and it does seem to help with just stabilizing things, and it can be started in the early stages of someone with acute chest syndrome. It may help with if they have a productive cough in terms of with physio as well, and we would use regular nebulizers every 4 hours initially. And again, in a patient who comes in who's got Sickle, who's wheezing, have a low threshold to do a chest X-ray, just to make sure they're not developing infiltrates there, and you may need to repeat it. Use of steroids. So our patient did get dexamethasone, and steroids actually are very helpful in Sickle because they are very good at reducing inflammation, which is a large part of the whole Sickle picture. The problem is that if you give steroids, you then get rebound pain when you stop, and this is often acute vaso-occlusion. And although you might reduce their length of stay, it was identified a lot of them would just need readmission pretty shortly after discharge. And again, it's to do with the upregulation of the inflammatory endothelial molecules, probably as much as anything. One of the worries is the steroids in the doses are used that cause problems with hypertension and also significant fluid shifts. And if you've got someone who's acutely sick with acute chest syndrome, where they may be a bit fluid overloaded, they're hypoxic, you're doing an exchange or transfusion, you can get quite dramatic changes in their blood pressure, and there is an increased risk of stroke, particularly hemorrhagic stroke. And this can occur in someone who's got no previously identified stroke risk factors. So they might have normal Dopplers, they're not thought to be in the high risk group, but we have seen this, and it's probably sort of vascular changes acutely, and it is intracranial hemorrhage, which is obviously very serious. So it's reserved for the most severe acute deteriorating patients, and there's evidence in children that it can avert the need for intubation in those selected patients if you use it at the right time. It's certainly not standard treatment, so I don't want you to think that anybody coming in with acute chest syndrome just gets steroids, because that would not be correct. But it can be very helpful in shortening the episode or avoiding intubation. If they are started, they have to be weaned slowly because of the risk of the rebound problems. And again, you might think about using them in a child with asthma, and I think that is entirely reasonable, but just go for the slow wean. If you're using it in asthma, you're going to be using lower doses than we use for the acute chest, which is, as you can see there, dexamethasone, which is a pretty hefty dose. So in a big child, you're going to be giving 15 milligrams BD for 48 hours and then wean slowly. Yes, I think we always think carefully before we use it because of the known risks associated. Just mentioning this fat embolism syndrome, this is a really unpleasant thing that can happen. It's usually in the setting of a severe vaso-occlusive episode, particularly in the legs, where someone will suddenly deteriorate in front of your eyes. They become hypoxic, they're obtunded, they appear shocked, and their oxygen requirement goes up, and you find may have sudden chest changes in the x-rays. And if you do an MR or CT, you'll see MR rather, these micro hemorrhages throughout. And this is where this situation where you get infarction of the bone marrow in the long bones, and then it embolizes up into the rest of the circulation, and it does travel up to the brain. Very dramatic. There's often petechiae and drop in platelets. Corresponding also with the changes in the brain. It can be associated with multi-organ failure and an ARDS picture, and the confusion and agitation is often part of this. It's particularly been associated with parvovirus B19, which we know can cause very extensive marrow infarction. So a child who's in with a sort of falling hemoglobin, very severe pain, low retics, you might wonder if they've got parvovirus, and we've seen this happen. And these patients need red cell and plasma exchange in a PICU setting, but can make a good recovery. We've had a couple over the years who've had this, but it's quite uncommon, but we do see it. So thromboembolism, we know that all patients with sickle cell are at higher risk of thrombosis due to the background inflammatory state, but particularly post-pubertal children who are behaving more like adults. The problem is that the features of a pulmonary embolus can overlap with acute chest syndrome, just pain, hypoxia, and D-dimer isn't really any help because it's increased in any sickling episode and acute chest syndrome, so you can't really use that to distinguish. So be mindful of this possibility in someone who's been lying in bed, immobile, on opioids. We would recommend using prophylactic low molecular weight heparin, particularly for postpubertal patients, but this would be contraindicated if they're known to have a proliferative retinopathy, whereas the risk of intraorbital bleeding or intracranial bleeding risk. But there is evidence, increasing evidence now of it benefit in managing acute sickle episodes generally, painful episodes. So I think we're going to be moving to a situation where it will be standard part of treatment, particularly for patients just because they have an acute sickle episode. For those who do have you think this they are I think the trouble is if your thought crosses your mind, you're then really obliged to follow it through. So the patients where you think it's a possibility getting an urgent CTPA, particularly for sudden deterioration where they get severe pain, or unilateral pain particularly, or desaturations, CTPA to assess them for emboli with thrombolysis would be appropriate. So in terms of monitoring, as I've said, just I think the monitoring of sickle patients is key to just about everything. All the evidence historically points to the fact that patients do badly if no one's keeping an eye on them, and particularly in the adult world, unfortunately, that 50% of acute chest syndromes develop on the back of another reason, so a surgical admission or coming in with pain. So you've got to keep it in mind. Any child can progress. There's always a risk of this getting worse. So early aggressive treatment, and the clinical signs can precede the X-ray changes. So if you examine a chest and you think I can hear crackles at the base, always believe your findings because the chest X-ray may lag by a few hours. But if you get falling SATs, you can hear the chest signs. Act on that on your findings and keep reassessing. Important to just highlight the neurological complications. I've already said that if you've had a severe acute chest in the last 2 weeks, you're more likely to have a stroke. There's also the acute complications of seizures, PRES, posterior reversible encephalopathy syndrome, usually in the patients having transfusion and hydration and so on, and intracranial hemorrhage. Then you need urgent CNS imaging, which would have to be a CT in the first instance to look for a bleed, but then MRI, MRA to assess further. And just again, depending on where you're working, the Pew score does not include neurological assessment, so you've always got to bear that in mind when you're assessing them if they're getting obtunded or drowsy. For the patients where they have recurrent episodes, this so-called chronic sickle syndrome, sickle lung, restrictive lung defect deficit, it can lead to chronic hypoxia and pulmonary hypertension. We know that of all the patients, those with SS and S beta 0 thal have probably highest risk of most severe ACS, and the level of fetal hemoglobin level is usually partly protective, which is why we know hydroxycarbamide, hydroxyurea reduces the risk of acute chest syndrome, but it can occur in any phenotype, and HBSC patients are just as likely to get acute chest syndrome as others. Just to mention these two things which you may have come across, there's the recent all-parliamentary group document that was published during COVID called No One's Listening, which is really based on the experience of some adult patients who died due to failure to recognise their acute chest syndrome. One was a young adult patient in his teens, I think, who was in a hospital. He'd gone in with a painful episode, been put on a surgical ward. He kept saying, I'm not right, and asking for help. And in the end, he called an ambulance to his bed in the hospital because he said no one was taking any notice, and no one had told the Sickle team he was in, and he actually did die of complications because it was too late to intervene. And it's worth having a look at this. It's a very salutary document, but it highlights the need to evaluate and monitor patients particularly, and listen to them if they say things aren't right or if parents say so. Preceding this, I think this was another document which was very key, which was an NC-POD review of all sickle deaths that they could identify in the country, trying to tease out the factors. And again, it did come down to inadequate monitoring, inadequate frequency of reviews, and preventable deaths, which unfortunately is still a problem. But I think, you know, with good network, good communications, we can avoid all but the worst cases where, despite everyone's efforts, things still go badly. But I think that's everything I was going to say. Thank you very much.